Hello, everybody, and welcome to the OrthoNinja Academy. My name is Amer Shoaib. I'm a consultant orthopaedic surgeon in Manchester in the United Kingdom. I'm joined today by my colleague Raheel Shariff, who's a consultant in Jeddah in the Kingdom of Saudi Arabia.
Hi, Amer.
Right, and today's subject is the flat foot in adults, and this is a little bit of an enigma. It's a very common subject in exams because it's one of those conditions which is quite stable, and there are plenty of people who are suffering from it. But you need to be able to talk convincingly about how you're going to assess and manage this condition. And hopefully after Raheel's talk today, you'll be able to do that. So let's start off by looking at a case. So I'll have a look at case one. Okay, so we're going to start off with a relatively young patient who's 20 years old, who's got bilateral painful flat feet. And this woman is afflicted by pain when she's been walking up for not very long. 20 minutes at the age of 20 years old is quite a disability. She's tried insoles and they're not helping her. So we need to ask the question, what are we going to offer her? So there's a poll out here now, and these polls, these questions that we ask you, we don't know who's given which answer, and so it's completely anonymous. So what we'd like you to do is to give us your best guess of what you think the appropriate treatment is, and then we'll go through the answer with Raheel, who will explain to us how we should go about thinking about the decision making. So let's see.
What would you do in this case?
Well, she's only 20, so I would be thinking, well, why she got this pathology? Because that's quite young to have pathology. So if somebody has got is not middle-aged and they've got pes planus pathology, especially if it's painful, I'd be looking for some pediatric conditions. So I'd be thinking, well, is there anything that's irritating the subtalar joint, like an osteoid osteoma or inflammatory arthritis? And I'd also be looking for something like a coalition that might explain why they'd have a painful flat foot. And then once I'd sort of excluded those sort of more pediatric causes, I'd then go on and assess for the adult causes. So we've had a few answers. We've still got a few people left to give their answers. Whoever hasn't answered, just have a guess, because we don't know which answer any individual's given. There's no pressure. It's just
to get a flavor of where we are as an audience, where we are as a group, because we've got peers, we've got colleagues amongst us, we've got young surgeons amongst us. The majority seem to be heading towards a diagnostic injection into the subtalar joint, which tends to make sense if the problem is in the sinus tarsi, the pain is in the sinus tarsi. Now, in a young person, I think the top tip from this take-home message is, if you've got a young person, make sure you mobilize their subtalar joint, examine it to look for mobility, and if there is lack of mobility, we've got to think of a coalition. So what investigation would you get, Amer? Would you get an MR and a CT scan to look for a coalition, or one or both?
I generally go for a CT scan to look for a coalition, but okay. I'd have a low threshold for both.
Correct. Okay. So let's move on. Clinically, this patient has, Amer, do you want to take this?
Yeah. So these are some interesting X-rays. We've got valgus hindfoot bilaterally, and the arch is pretty flat. Now, stage 2 deformity suggests that this is a flexible deformity and it can be clinically corrected. So if do you want to go through those X-rays for us, Raheel? Just to describe the X-rays, starting with the left-hand one.
The first thing we all look at is on that lateral X-ray. We all know the Meary's angle, which is that long axis of the talus and the long axis of the first metatarsal. It's in pretty much 10 degrees of negative here. We want it to be looking up like that. It's probably down this way. The first thing I look for is the talar declination. Sometimes we tend to have what's almost a vertical talus masquerading as a flat foot. And those are quite challenging to correct. The reason we have these residual problems in flat feet is because we don't get that talar declination bang on back to where it should be. And through the course of this talk, we're going to go through some tips and tricks on how we do this. In the AP view, we're looking in that middle picture, we're looking at the talar head and the uncoverage of the talus. Now, Amer, does this particular point on an AP view change your management with regards to surgical options you provide for this patient?
Well, it does, because if you've got a significant degree of abduction in the foot and there's uncovering of the talar head, then it makes you concerned about what the pathology might be.
Okay. Yeah, I agree. In my mind, usually if there's talar head uncoverage, I'm thinking more in favor of a spring ligament attenuation or a tear, because remember that spring ligament, there's a plantar limb to it and there's a medial limb to it, and that talus is almost sitting in it like a hammock. So if that hammock is getting stretched, your talus is sort of, almost going downwards and getting uncovered because that medial limb tends to stretch out. And the other thing in that oblique view we look for is if there's any evidence of a calcaneonavicular coalition with beaking of that anterior process of the calcaneus. So this patient does have what we call a flat pancake kind of deformity. So the question we're going to ask now is, what are you going to do with this patient? Okay, so we're diving into the surgical options. Amer, what are your thoughts?
Well, if we've excluded any other kind of pathology, it's quite
let's
young.
assume this patient does not have a coalition.
Yeah, there are two things that we need to think about. One of them is the fact that there's a three-dimensional deformity of the foot, and that's including the calcaneus. It's the Achilles tendon is going to be involved because of the valgus of the foot. The Achilles is going to be taking a shortcut, and that's going to be maintaining the deformity in valgus. I'd always be concerned about the spring ligament, and I'd be wanting to medialize the heel and support the arch in a new position. I know that if you do a soft tissue procedure alone, then about half of them fail. So it's got to be a combination. It's got to be a bony procedure plus or minus a soft tissue procedure in order to redirect the heel so that it's retensioning the arch again. So calcaneal osteotomy and FDL transfer, I think that's a reasonable option. Calcaneal osteotomy with the spring ligament reconstruction, I think pretty much in all of these cases I do reconstruct the spring ligament. And FDL transfer, again, that's a reasonable option. Spring ligament reconstruction, FDL transfer, and lateral column lengthening, again, that's a reasonable combination. And calcaneal osteotomy, spring ligament reconstruction, and lateral column lengthening, again, that's a reasonable option. I personally would go for a calcaneal osteotomy plus spring ligament plus FDL, but lateral column lengthening is also an appropriate procedure in a patient who's younger. So what would you do, Raheel? What would influence your decision making?
So that this is we're going to discuss this in the course of the talk. We'll unpick each of these and see which ones work well in combination with what. Now, there is a school of thought which goes purely with bony correction. So they would do a calcaneal osteotomy and they would leave it at that, or do a calcaneal osteotomy and do a lateral column lengthening and not touch the medial structures, i.e. the spring ligament and the tib post or the FDL. The thought process being, there's no way that soft tissue is going to be able to correct it alone. So just get the bony levers corrected and leave it as is. So they have their modus operandi for that. The other option is to use a combination of the two. Now, in my hands, lateral column lengthening comes into its own when there's more than 30 to 40% uncoverage of the talar head. I would have a low threshold, particularly in a young person, because you don't want them to have a recurrence at the age of 40 or mid-30s, 40s. interestingly, the audience seems to go with number 3. So that's a lot of procedures being performed. I would agree with what the audience is saying here, because a lateral column lengthening is a powerful correction. But bear in mind, have the nuance intraoperatively to be flexible with your decision making. And that's what we're going to look at through the course of this talk. Okay, so this was the X-ray, and this is what I did. I agree with the audience. I did a calc slide. I did a FDL tendon transfer. In that AP, I'm not sure if it projects very well, but you can see the the interference screw, radio lucent one, in the navicular, with a spring ligament reconstruction and a lateral column lengthening. As you can see, that's a standing X-ray. You can see that the tailor head is completely covered now compared to where we were there.
Yeah, that's a really good reconstruction. Can I just ask you a question? Can I ask you another question there?
Sure.
So there are some people, if we go back to that X-ray, for the correction of the hindfoot position, so there are some people who use arthroesis screws, and a lot of people in the audience may be wondering, well, what's the role for the arthroesis screw? Have you got any experience of using that?
So my experience in taking them out far outweighs my experience in putting them in. Arthroesis screws, I do have a role to play in the pediatric age group, because a lot of pediatric surgeons tend to use these. In the adult population, the literature shows, for those who are wondering what the arthroesis screw is, because we've got some young people in our audience as well, it's a kind of a device which goes into the sinus tarsi, into the subtalar joint, almost like a blocking screw, and jacks the subtalar joint open to correct that talar declination, as well as get the hindfoot into a more neutral position. And you leave that screw in. It's not within bone, but it's in the subtalar joint itself, in the sinus tarsi, and take it out later. But in the adult population, arthroesis screws have a 50% incidence of pain, persistent pain, and almost all of them have to be removed. So I do agree it has a role to play in the pediatric population, but in the adult population, I don't tend to use it because of what the literature suggests.
That's exactly, that's what I feel as well. There's such a high rate of removal. And we said before that if you do a soft tissue procedure alone without a bony procedure, it's pretty much destined to fail. And the arthroesis screw was an attempt to decrease the amount of bony surgery. But if you're taking them out, then you've got to worry, well, what's going to happen to your soft tissue reconstruction? So I think that although there's no clear guidance on the use of arthroesis screws, the high rate of removal means that in my hands, I think it's not the ideal way to treat the deformity. Okay, that's great. So I think we've got another question to ask. So what surgical considerations should we take into account while performing a lateral column lengthening? So one of the problems that we could cause is the subtalar stiffness, posterior facet impingement, calcaneal cuboid joint arthritis, none of them or all of them. So it's a difficult question, but can you make your choices now? So everyone in the audience,
okay, so this is a tricky question, because I know a lot of people won't have any experience with lateral column lengthening, but it's important to understand, if we're going to be offering a treatment option to patients, what can go wrong with that. Let's see where we are. Okay, so interestingly, we've had some of the audience answer, possibly because they're quite experienced with this procedure, and they've gone with all of the above. The right answer is all of the above. It does cause subtalar stiffness. It can cause posterior facet impingement and calcaneal cuboid joint arthritis if you distract and compress that CCJ quite a bit. While we touch upon the talk and the lateral column lengthening procedure, we can look at tips and tricks on how to avoid these problems. Okay. Finally, we've got one more question, Amer.
Okay, what type of graft would you prefer? So tricortical autograft, because it's...
This is called the lateral column lengthening, right? Yeah.
Right, yeah. So it's tricortical because it's got some structural stability and it's If you're taking autograft, then it's going to be osteogenic and osteoconductive. So that's one option. Structural allograft, we're talking about donated bone, so that's not going to be osteogenic or osteoinductive, but it will be osteoconductive, and either does it make any difference? So it's an interesting range of answers we've had so far.
Mm-hmm. So would you use allograft?
I think I would, actually. I think I'd be looking for the structural stability and having the biological essentials of the osteoinduction, osteoconduction, and osteogenicity.
So you'd go for an autograft, sorry.
I would do, yes.
So a tricortical, okay, yeah, so fair play. I think the vast majority have agreed with us on that one. Okay. That's the end of the first case. What we're going to do is dive into a session on how to approach a flexible stage 2 flat foot. Okay, I'm going to share my screen with you because some of the videos don't allow us to upload on because there are quite a few. Okay, can you see my screen now?
Yep.
And the talk.
That's perfect. Yeah, the talk is up now.
Excellent. Okay. So here is a poll. Amer, I'd like you to push this one to the audience. The most likely cause of flat foot in a 35-year-old is plantar fascia rupture, tib post tendon dysfunction, spring ligament insufficiency, or a tight Achilles tendon. Where are we at?
So at the moment, we've only had a few people answer.
What's your answer, Amer?
Well, I would be looking at this. Well, I'll let the audience answer a little bit. A few more of them answer first.
Okay.
But in a 35-year-old, I might be looking to see whether there's any inflammatory disease, that because 35, for me is quite young to have an acquired flat foot. But for me, the first thing that I'd be looking for is the spring ligament, and that's actually the answer that the majority of the audience have gone with as well.
Absolutely. So the key take-home message: if you've got a young patient with a flat foot, think spring ligament, not tib post dysfunction, because that's usually in the older ages. Okay, here's another one. A mobile hindfoot valgus. So a valgus of the hindfoot which is correctable with the correctable forefoot supination is a stage 2A, a 2B, stage 3, or a 2C deformity. Now, I know we don't like classifications in the FRCS exam and other such exams, but it's important sometimes to understand classifications because they help you in managing these, whether you're going to go down the surgical route or not. We'll put everyone out of their misery here because I know everyone hates classifications. The correct answer to that is a stage 2B deformity. So for those of you who got it right, excellent. Okay. So what are we going to look at in this talk? Okay, we're going to recognize the deformity of the flat foot, easy to look at, but we're going to break it down into what happens in the hindfoot, what happens in the midfoot, and what happens in the forefoot. And this is going to help us in classifying it and aiding in our management. We're going to look a little bit into the anatomy and the biomechanics of why the tibialis posterior tendon seems to be the most commonly affected. What is it that makes this tendon the common culprit? There are lots of other causes besides the tib post dysfunction for a flat foot. We're going to look into these, how to assess this in a clinic, and how to go about treating this surgically. The majority of this is going to be looking at the surgical algorithm rather than the non-surgical for a want of time. So what is the deformity? Easy. The first step, always examining from back to front. We've got hindfoot valgus. Usually more than 10 degrees is considered a pathologic valgus. We've got the medial arch collapse, which we all know. And then what's happening in the forefoot? Once we correct the hindfoot to a neutral position, we've got to assess what's going on in the forefoot. And if our forefoot has supination or varus, depending on what terminology you use, which means that the first ray is higher up than the fifth ray, as you can see in this picture, that is a forefoot supination. And you've got to look for this, because if you don't correct this and just correct the hind foot, the patient will have a non-plantigrade foot following the correction. Now, here's the question. Are all flat feet pathologic? The answer obviously is no, because 10 to 25% of the population tend to have these, but only a minority of those tend to be symptomatic. And this was corroborated by this paper by Harris and Beath, who looked at Canadian Army recruits back in the 40s, and 22% of these fit, healthy, young people had flat feet, but they did not have any functional pathology. But bear in mind, if it's unilateral, you've got to consider a pathology. You've got a whole spectrum of deformities. You've got the normal, you've got the pathologic, and then you've got the really crazy ones, which you've got to sort of phone a friend to correct. And we're going to look at how to deal with each of these through the course of this talk. Quick deep dive into the anatomy. You've got static stabilizers and dynamic stabilizers for your foot. Your static stabilizers are the shapes of your bone. We discussed in this Liz Frank talk the week before last, where Amer spoke about that Roman arch. That helps to create part of the arch of the foot from the trapezoid shape of the cuneiforms. You've got the plantar fascia, which is a static stabilizer, and the spring ligament. Now, we all keep talking about the spring ligament, and it's quite important, and we don't pay attention to it often enough. And that's what gives rise to a correction which may not be adequate. So a spring ligament, as we know, has these two limbs to it. It's got a plantar limb and a medial limb around on which the talus sort of sits. It's essentially starting from the calcaneus and working and moving towards the navicular. And on an MRI, it's so arrow number 1 shows the posterior tibial tendon. So if you look at the semi-coronal oblique cuts in the MR, you look for the spring ligament, and the arrow number 2 is what the spring ligament looks like. So it's just kissing the tib post tendon, and in certain instances, it can have an intermediate signal, as you can see on this picture in B, suggesting a pathology within the spring ligament. So those are your static stabilizers. You've got your plantar fascia, you've got the shape of your bones, and you've got the spring ligament. So a quick word on the dynamic stabilizers. Your dynamic stabilizer is essentially your posterior tibial tendon. Okay, that's the be-all and end-all of your dynamic stabilizer in the foot. It blends with your deltoid and spring ligament complex. And besides that, you've got the intrinsic muscles as well, but the predominant dynamic stabilizer is your posterior tibial tendon. It's got a broad insertion, as we know, inserts into pretty much most bones except the cuboid. And the fifth metatarsal. That picture there is erroneous. It's not going to the fifth metatarsal. And it's the main inverter of the hind foot. Now, I know Amer will possibly disagree with me to an extent on hind foot inversion and the Shoaib joints. We've been having this talk just recently. But the posterior tibial tendon, for all practical purposes, is what swings the foot into varus. So that's to do with the anatomy and the applied anatomy and the stabilizers. The question is, what causes a flat foot? Okay, you've got a whole host of causes: spring ligament, inflammatory pathology, as Amer has alluded to earlier, arthritis. You've got to look at your first tarsometatarsal joint, because instability in that joint can also give rise to a flat foot. So bear in mind, if flat foot is not just, so if this is the arch, the flat foot is just not the tibialis posterior tendon stretching. It could be further distal in the arch, the spring ligament. It could be the first TMT joint, the navicular cuneiform joints. All these could be stretched out, the capsule and the joints, causing a flat foot. Posterior tibial tendon has the most obvious pathology associated with the flat foot because it's commonly seen in women, but importantly, it's seen in women in their middle age, so 50 and 60-year-olds who are often overweight. Some of the associated factors, Mann looked at this in his article in '92. Hypertension, obesity, diabetes, previous surgery or fractures, and steroid exposure have all contributed to PTT rupture. So here's the age-old question. Is it overuse and age-related, or is it a vascular issue which gives rise to a posterior tibial tendon dysfunction and tendinopathic nature? So you've got two phenomena here. You've got the mechanical phenomena and you've got the vascular phenomena. The mechanical phenomena, we know that the tibialis posterior tendon bends acutely around the medial malleolus. Where it bends just behind the medial malleolus, it has quite a large amount of compressive fibrocartilage within its tendon substance. And that helps to almost counter these shear forces every time the ankle moves and it's being rubbed against that medial malleus. With age or with time, this fibrocartilage diminishes, and that gives rise to this mechanical phenomena of atrophy of the tendon. The other theory touted is by Frey in the JBJS in the 90s, where he talked about this vascular watershed area within the tendon. So where the tendon attaches into the muscle, higher up proximally, you've got a muscular tendinous junction with good blood supply. Where it attaches into the navicular and the bone, you've got this intraosseous blood supply seeping into the tendon insertion. But in between those two, you've got that watershed area where there is not a phenomenal amount of blood supply, and that's usually 14 millimeters from the insertion for about 4 centimeters. That's that area we're looking at. All these contribute to making the posterior tibial tendon prone to tendinopathic pathology. So here's the question: what comes first? Is it the spring ligament which stretches and then causes tension on the tibialis posterior tendon, or is it vice versa, the tib post stretching and causing a pathology to the spring ligament? Amer, do you have any thoughts on this? It's almost chicken and the egg scenario, isn't it?
Right. Okay. Well, there was a paper in 2014 which said that the spring ligament was always the first thing to go, and quite often you find that when you test people's power who've got flat feet, they still seem to have pretty good power of 5 out of 5 MRC grade in their tib posts. So I'm actually quite convinced already that the spring ligament is the first thing to go, and having lost that mechanical stabilizer, then the posterior tibial tendon is put under more strain and that starts to stretch.
Okay. So yes, we won't know whether this is right or wrong. Everyone has their theories. I tend to agree with you because bear in mind, in the younger age group, it's the spring ligament which tends to have the pathology. Once we've ruled out a coalition. So if they're younger and the spring ligament is the culprit in the young age, it sort of just makes sense that that's thinning out and that's causing stresses on the tib post, but we will never know. So here is a video of the spring ligament to demonstrate so that's the spring ligament there which is being excised. It's quite synovitic. This is an inflammatory arthropathy patient, and just as we move, that's the tailor head which you can see behind the scalpel there, and just coming into view there is your FDL tendon, which the scalpel is sort of coursing through. That's the posterior facet of the subtalar joint coming into view there. So here's your synopsis of your flat foot development. You have your spring ligament which attenuates. Amer, you were right on that one. We both agree with this. That causes your tailor head to plantarflex, because remember the spring ligament is sort of holding that tailor head in a hammock sort of position. Once that happens, your transverse tarsal joints abduct, your calcaneus swings into valgus, and with time the Achilles tends to contract. There is a overpull from the peroneus brevis on the lateral side, which causes your subtalar joint to evert. So that's the whole sort of spectrum of the development of your flat foot deformity. How do we assess these patients? A quick word on this before we dive into our surgical options. So always, whether you go from the front to the back or the back to the front, have a systematic way of assessing these patients. You've got hindfoot valgus. From the back, you've got your medial arch collapse and your forefoot supination. Beyond 10 degrees of valgus is pathologic. And you've got your too many toes, which we love to quote in the exam. And the question is, how many toes is too many toes? Okay. Any thoughts on this?
So I normally say you compare to the other side, but there's a possibility that you might have bilateral deformities. I think more than 1.5 toes visible from the back for me is pathological.
Okay, so fairly, I think more than 2.5. So this just goes to show it's quite a subjective test, this too many toes test. But what isn't subjective is your tiptoeing bipedally and unipedally. So as you can see in this patient, as the video is playing, look at the heels and look how they swing into varus. So this is your tibialis posterior tendon functioning. It's a main inverter of the ankle as we discussed, and that's swinging that heel into a varus position. So this shows this patient's tib post is functioning. So you've assessed the hindfoot, you're moving on towards the forefoot. Okay, in the forefoot, this figure A shows the heel in valgus. And once you've corrected it to a neutral position, look at what happens to the forefoot. You've got this forefoot which has swung into supination. And essentially, how do you recognize that your first ray is higher than your fifth ray? Okay, and now you've got to assess whether this forefoot supination is flexible. So if you've swung it into the heel into a neutral position and your forefoot has gone into supination, with your other hand, can you just swing it back into a neutral position? So can that first ray get plantar-flexed to come down to a plantigrade foot? If it does, that's a flexible forefoot supination. If it doesn't, it's a rigid forefoot supination. Okay. And finally, you look for your Achilles or gastroc tightness on the Silver-Scolds test. As you can see in this picture, a lot of people understand the principles of the Silver-Scolds test, but when it comes down to the nitty-gritty, they fall apart because we don't understand what is positive and what is negative. It's easy. With the knee extended, this video is on loop, so we'll go through a few times. When you dorsiflex, if your foot is not coming up to neutral, or comes up to neutral but doesn't come up to 5 degrees of dorsiflexion with the knee extended, that means either your Achilles is tight or your gastroc is tight. So you have to get at least 5 degrees of dorsiflexion with your knee in extension. If it isn't, then either the Achilles or the gastroc is tight. Once you flex the knee, you need to be able to get it into a further 10 degrees of dorsiflexion beyond neutral. That suggests both of them are okay. If they aren't, then it's your gastroc which is tight. Okay? If there's any query regards this or anything during the course of the talk, please post in the chat box, and we'll be happy to take those questions, and Amer will answer them for you, or I will have a stab at it. Okay. So this is your Silver-Scolds test, which is vitally important because you will need to consider an Achilles lengthening or a gastroc recession. So here is the classification, Meyerson's modified classification, and we're going to quickly go through this so that this helps us in our surgical planning. Stage 1 is normal looking foot, no deformity, but there is tenosynovitis of your posterior tibial tendon. Patient will have a bit of fullness around the course of the posterior tibial tendon, a bit of inflammation and pain, as you can see in this picture here. Stage 2 is there is tendinosis, but it's a flexible flat foot. Okay, so your hind foot corrects into neutral, as you can see here. So the 2 is where the controversy comes into play. Okay, so 2 is divided into 2A, 2B, and 2C. And each of those we're going to go through in a moment now. So we know a 2 is by definition a flexible hind foot. So what is a 2A? A 2A is a hind foot which you can swing into a neutral position, so it's flexible. But when you correct it, as you can see in this picture in B here, there is no forefoot supination. So the forefoot stays in a plantigrade position once you correct that heel into a neutral position. A 2B, once you correct that heel into a neutral position, so in A, the heel has been corrected compared to B, you see there's a touch of forefoot supination, okay? But that forefoot supination is flexible. By that we mean you can bring that first ray down and swing that forefoot back into a neutral position with the heel corrected. A 2C is when you correct the heel, so the hind foot is still flexible, but the forefoot is rigid. So there is supination, but the forefoot tends to remain rigid. You can't passively correct it and bring it back to neutral, the forefoot. Stage 3 we understand is fairly straightforward. It's a it's a fixed deformity, and stage 4 is a fixed deformity with the ankle tilting into valgus, which means the deltoid is also beginning to go. So 2A, 2B, 2C are the keys, and that's what we're going to focus on in the course of this talk. With regards to tilting, we always get 2 views because we want the full picture. So in fact, in the foot, you want to get 3 standing weight-bearing views. And what are we looking for? We're looking for that tailor first metatarsal angle. Okay, so the long axis of the talus in the AP in the figure on the left, and the long axis of the first metatarsal. And we're looking at the tailor head uncoverage. As you can see in that picture on your right, almost 30% of that tailor head, or possibly even 40% of that tailor head is uncovered, the articular surface of the tailor head. So the navicular has sort of swung out, and usually you're meant to have the navicular covering the entire tailor head, pretty much almost close to 90%. In the lateral view, we've discussed the Meary's angle, but one more pointer in the lateral view is your distance of the medial cuneiform from the floor. And usually, if it's less than 17 millimeters, you're going to consider a subtle flat foot. So here are our options in a synopsis. If it's flexible, basically once the patient has exhausted non-surgical options, we're looking at the surgical means. And if it's flexible, we're going to do tendon transfers and reconstruction with osteotomies. If it's rigid, we're going to consider a dipple or a triple. Amer, just a quick thought. We're not going to dive too much into the fusions, but do you tend to routinely do a triple or a dipple?
I tend to do a dipple, a double. Yeah. I tend to do a double osteotomy rather than a triple, because essentially I think you fixed 95% of the subtalar movement with the tailonnavicular joint and the subtalar joint. So I don't think there's a need to fuse the calcaneal cuboid joints as well.
Okay, it's interesting. So we agree on that, and that's just a take-home message. Although we're not going to go too much into the stage 3s, we're going to focus on the flexible stage 2s. Okay, always bear in mind you've got your non-surgical options, and give the patient the choice to use insoles. Medial-based heel wedges with the medial arm support tends to surprisingly correct the hind foot quite well, as long as you put the right insole for the right patient. So here's our surgical management. Okay, and this is your basic algorithm, which I tend to follow. It's pretty much steeped in evidence, so I would be fairly comfortable defending this. Your stage 1, you've got, in the evidence, there is talk of a synovectomy and a debridement of your posterior tibial tendon once non-surgical options like casting or bracing have failed for about 6 weeks. I've hardly ever done this in my practice. I'm not sure if it's currently used, but this is what the evidence seems to suggest. We're going to look at some papers on this. Amer, do you tend to do a debridement of the posterior tibial tendon?
So really
in isolation?
Yeah, the patients who we're going to find who have this particular, who are going to come in stage 1, are the patients who have got quite florid inflammatory disease. In the UK, by the time someone's reached us, generally they've reached stage 2, but the inflammatory disease patients may get to us a little bit earlier, and we can intervene surgically to debride their tendon sheath, and that's actually a very effective treatment for them. Mm-hmm. But unfortunately, the degenerative ones, by the time they've been referred by their family doctor, unfortunately, they've very progressed to stage 2.
Yeah, it's reflected in most of our practices that we don't tend to get these and catch them early enough to debride them. And the ones who have the inflammatory arthritis tend to do well with medical treatment these days, so we don't see these often enough. So stage 2, there's controversy as the multiple procedures described, and we're going to sort of look at a algorithm to just peg our tools on and when to use what. Stage 3, we fuse, and stage 4, we fuse dipples or triples with a deltoid reconstruction. So here's your posterior tibial tendon synovectomy. So this is a video showing you the approach to your tibialis posterior tendon. Your incision starts just posterior to the medial mal or just under the medial mal. And as you can see, the sheath of the PTT is being cut. And once you do that, you get your posterior tibial tendon under it. And you can see there's quite a bit of synovitis and a bit of tendinopathic tendon here. And it's quite thickened, as you can see. So if it's an early stage, you could just debride this synovitis and let the patient recover. And they're meant to do well with this. As I said, in my practice, it's very uncommon because I don't pick them up as early. So does it work? So here is a paper in the FAI in the 90s by Teasdale. And this was Ken Johnson's paper, Ken Johnson's group. And they looked at stage 1 PTT dysfunction with surgical debridement. 19 patients who underwent a synovectomy, and 74% had complete relief, and 16% complained of minor pain. Overall, 84% returned to function, and they were subjectively better. So there wasn't a hard analysis on this. So what do we do for these flexible flat feet? Okay, so as I said, we examine them from the back and work our way to the front. Similarly, with the correction, you start from the back and work your way towards the front. First step, you either do an Achilles lengthening or a gastroc recession, depending on which of these is tight. Because if you don't do that, you'll struggle to get your calcaneus into a neutral position with your bony correction. Once we've done that, we do a medial slide calcaneal osteotomy. And then we do your flexor digitorum longus tendon transfer. So you excise your unhealthy tibialis posterior and you transfer the flexor digitorum longus in its place. Now, there is some controversy here regards the young people. Most young people tend to have a spring ligament pathology. Okay, so if you're young and your medial column appears to be unstable, so how do you pick this up? You look at your tailor head uncoverage on your x-ray. you look at the degree of head declination. If you doubt, if you palpated the spring ligament area, you think it's not working very well, you could consider getting an MRI to look for attenuation or picking of spring ligament or injury. And in those, you consider a spring ligament reconstruction. So if the patient is young, almost always they will get a spring ligament reconstruction in my hands. Once you have done this, intraoperatively, you look at what's happening to the forefoot. Now you have corrected the hindfoot, you've lengthened the Achilles, you have done your calcaneal osteotomy, and you have neutralized the hindfoot. Then you look at the forefoot. If that forefoot is in supination, so your first ray is higher than your fifth, and it's passively correctable, you could consider a cotton osteotomy, which is a plantar flexion osteotomy through the medial cuneiform. So that, in a nutshell, is your surgery for your stage 2. As I said, there is controversies now about whether you sacrifice the tibialis posterior in a young patient and give them an FDL, which is a weaker tendon compared to the tibialis posterior, or do you just reef the tibialis posterior back in place? Amer, do you tend to do one or the other in a young patient?
In a young patient, I would tend to repair the spring ligament as you've done. People talk about whether you should sacrifice tib post. I tend to say, in general, in young people, they've got good power, so I don't remove that, but I would still do the FDL transfer as well, but leave them both in place. The only situation when I think it's absolutely necessary to remove the tib post is if there is a lot of adhesion. Yes, and basically that's going to prevent any gliding. But otherwise, I would leave it be.
So what do? Do you just cut the tib post or just retract it inferiorly, repair the spring ligament and leave it in situ, or you cut it, gain better access to the spring ligament, repair the spring ligament, and then reattach the tib post?
I would retract it, repair the spring ligament, and then I would leave it in situ and do the tendon transfer as well.
Okay, interesting. Okay, so these are the controversies which we discussed. The other thing to note is some people, if you've got a healthy posterior tibial tendon, a healthy posterior tibial muscle, they get an MRI. Mark Myerson tends to do this, and if the muscle itself has no fat atrophy, then he does he excises the tib post, then takes either a hamstring and pelvic tufts and weaves it to the tib post and reattaches it to keep the tib post muscle going. Okay, so we've looked at the approach to the posterior tibial tendon. The first step to do, you've got your Achilles lengthened, you look at your calcaneal osteotomy, and you want to displace this by about 10 to 14 millimeters, not beyond that. So here is a step-by-step approach. You've got your incision, it's an oblique incision at a 45-degree angle to the sole of the foot. It's about 2 finger breadths beneath the fibular tip. And once you've gone straight down to bone, you've got to bear in mind and protect your sural nerve branches here. You get a couple of home McDonald's and plump them on either side of the calcaneal tuberosity. On the plantar side, it's protecting the plantar fascia and the muscles, and on the posterior aspect is protecting the Achilles tendon. The reason for this is because you're going to get a fan saw blade, and you're going to take this to the bone to saw it down, as you can see in this video. Now, if you can see, my hand is on the other side, and the reason for that is I want to get some feel with the saw as to whether it's beginning to touch my hand. Once I feel that far cortex, I punch through that far cortex to get through the medial cortex. You've got to protect the neurovascular bundle, and one way of looking at that is look at your lesser toes. If they start flicking, you know you've reached that far end. Once you've done that, you distract this with a laminar spreader, and a top tip is put the spreader in, put it under as much distraction as you can get, and then just walk away, have a chat with your team, with your scrub nurse, ask them how their holiday was, give it a minute or so. That is going to really distract that calcaneal osteotomy and allow it to slide once you're ready to slide. So give it a good 2 to 5 minutes with this distraction if you're going to struggle, okay? Once we've done that, as you can see here, we have displaced it medially, and there's a 3.2 wire which I have placed as a joystick within the substance of the coxal fragment and levering it medially to medialize that distal fragment of the calcaneus And the bottom end of that picture, you can see the drill bit going in where the screw is going to go in. Once you've done that and you've fixed it, you've slightly fixed it. Now there are ways of using a step plate or a screw. Either one works, whichever you have access to. Do you do anything different with your calcaneal osteotomies there?
So I've changed my practice and I don't do open calc osteotomies now. I use minimally invasive surgery using a burr. And that's slightly different because it obviously it's smaller. It's a smaller incision. It's just a stab incision. You can make your osteotomy. I normally use a chevron osteotomy. By using a burr, it's normally 3 to 4 millimeters wide, and that actually removes some bone as well, and that generally gives you a little bit of soft tissue laxity, and you can get quite a decent size shift of 14 millimeters. So it's quite a powerful way of doing it, but you do a little bit of bony height as well.
Yeah. So there's many ways to skin this cat. Open, MIS, they all tend to work quite well. So you've done that, you've done your lateral side, you close your lateral side, and you switch over to your medial side. And we're now going to look at the FDL tendon transfer. Okay, so this landmark is your medial malleolus, the uniform joint. You can do that by palpating, but if you want to X-ray into one position, and that's your
Okay, so we seem to have lost Raheel there, but I've just sent him a text and hopefully he'll be back with you. There are so many different procedures for managing the flexible flat foot, and really it's a question of going through the literature and looking at the procedures that you've done when you were training, and then trying to decide which of those combinations is going to be best for you. Let's see if we can get Raheel back. While we're waiting, if you can hear me, has anybody in the audience got any questions that they'd like to ask while we're waiting for Raheel to reconnect? Just feel free to use the chat and ask any questions. So Raheel sent a message saying he's trying to get back. Just a technical glitch. And have you got any questions that they'd like to ask on what we've discussed so far? Okay, so Marwan's asked an interesting question. Is it just medial displacement, or could you use a lateral open wedge osteotomy as well? Well, essentially, it depends on how much of a displacement you've managed to get.
Can you hear me? Hello?
Because if you've... Oh, you're back on. You're back online again,
Sorry about
so we
that.
can hear you now.
Tell me where you lost me. I'm going to screen share again.
So I think we lost you just as you. I can't remember what the last slide was. If you go.
Can you hear me now?
Yes.
So we were talking.
Yes, I can hear you. I'll just answer. Okay. I was just going to answer Marwan's question. Yeah. So it's an interesting question because it depends on how much medial displacement you've got. So if you do your medial shift, if you've got enough and you're content with that, then you don't need to do a lateral opening wedge osteotomy. The problem with the medial shift alone is that you're just getting movement in one dimension. And the advantage of the lateral opening wedge osteotomy is that you're actually changing the geometry of the hind foot in 3 dimensions. And if you haven't got enough of medial displacement, then doing an opening lateral wedge to augment this might give you the correction that you need.
Okay, so we were talking about, yes, we were talking about the FDL tendon transfer. Is that where you lost me? Okay, so as you can see, once you've excised your posterior tibial tendon, you can start seeing a hint of the FDL where that scalpel is pointing towards it, and you track it down to the knot of Henry, which is where the FHL crosses the FDL. You cut it as distally as possible. There's always a sheath of vessels there which you've got to buzz, otherwise it bleeds in the sole of the foot intraoperatively once you release the tourniquet. And then you whip stitch that. You drill a tunnel through the navicular, and usually you do it either from plantarward dorsally or dorsal plantar. I tend to use a 5mm or a normally a 5mm drill bit, cannulated drill bit, and a top tip. You can use the ACL tray, which has these. So you can pass a guide wire, check it under X-ray to make sure you're in the center of the navicular. You're not going to blow it out with your drill and drill. And the reason I use a chunky drill is because I'm going to use a 4.75 interference screw passing the FDL with a spring ligament fiber tape as well. So as I said, so that's a picture showing once the FDL has been passed from plantarward through the bony tunnel and out dorsally, and it's being pulled back to get as much tension as possible. Which brings us to a spring ligament reconstruction. I always tend to use a spring ligament in a young adult, or almost always, because I want to reinforce that medial side. And here is a quick look at that. So I tend to use the fiber tape with bone anchors. The different commercial ones available. And you can see you've recreated a limb. You've got the FDL tendon, which has not gone in yet into that tunnel. And you can see that tape, which has been passed from dorsal plantar and one tape from plantar dorsal, as you can see in this picture, to recreate it. Okay. And once we've done that, we get the tension by plantar flexing the plantar flexing the ankle as well as plantar flexing the foot, and you can see the FDL is now beginning to get into that bony tunnel, and you really give it a crank to get the tension, and you can finish off by passing an interference screw from the plantar side through into the navicular tunnel. And you surprisingly get a good correction with this. So that's your pre-op image. As you can see, the talar declination and the Meary's angle has been corrected quite well with that. The question is, does an FDL transfer and a calcaneal osteotomy work, or is it just us kidding ourselves and hoping that the shape of the foot looks good? So the biggest paper has been done by Meyerson in 2004, looking at stage 2 flat feet with the use of a calcaneal osteotomy and FDL tendon transfer. They had 129 patients and a reasonably medium-term follow-up of just over 5 years. And what they found was 91% were entirely satisfied, and 97% had pain relief. And a reasonable amount regained some symmetric inversion strength as well. So all in all, it does tend to work for these patients. So let's do a quick synopsis now. We've got our, you can still see me, right, Amer? Because I'm screen sharing and I don't have much feedback here. Great.
Yeah.
So we've got your valgus of your hind foot corrected with your Achilles or your gastroc lengthening and a calcaneal osteotomy. But once we've done, and we've done our FDL tendon transfer or with your spring ligament if you have to, once we've done that, we've still got some residual forefoot supination. Now the question is, how do we correct this? Okay. it's important to get this foot into a plantigrade position to give a good outcome for this patient. And in those patients, you want to consider a cotton osteotomy, which is essentially a dorsal-based opening wedge osteotomy through your medial cuneiform. You can some modifications are done through the first metatarsal head, but predominantly the medial cuneiform is where you go, and that's pretty much your osteotomy there. As you can see in that picture, at the medial cuneiform, there is a single staple which is holding a dorsal-based opening wedge osteotomy where you've planted some structural ortho or allograft in there. Question is, how important is a cotton osteotomy? So this is a paper by Amitabh Iyer. He's a colleague of mine who was on fellowship with me. And this is from the FAI, fairly recent paper, which has looked at the contribution of your medial cuneiform osteotomy in your longitudinal arch correction. And they came up with this interesting angle, which is the cuneiform articular angle. Okay, so how do you measure this angle? You look at articular surface, proximal articular surface of the cuneiform and the distal articular surface, and just draw a line tangential to those two. Okay, normally it's about 0 to 0.6 degrees, and if that line tends to coalesce, that suggests that your arch is being corrected. And they sequentially looked at the size of the graft, the amount of graft which is being used, and the degree of correction that it was achieving. And they found that it was correction of your longitudinal arch was influenced by a graft size in a fairly linear fashion. And it was found to be quite a powerful correction of a corrective osteotomy for your medial longitudinal arch. Which brings us to our lateral column lengthening. So these are all the additional bolts and braces that we're using for our correction once we've done our calc slide and the tendon transfer and the spring ligament. Yeah. When do you do an LCL? So if you have a talar head uncoverage of 40%, you should be fairly comfortable doing a lateral column lengthening. What do we mean by that? So if you look at that picture on the left, that's your talar head, the articular surface, from the medial pole to the lateral pole of the talus, where the articular surface is. If you draw that out and you find that the navicular has uncovered the talar head by more than 30%, or more than 40%, then you're quite safe in considering a lateral column lengthening. Some people go with more than 30%. And here you can see there's 50% uncoverage of that talar head. And a lateral column lengthening will help to swing and bring that foot back into an adduction, adducted position, and cover that talar head. Take the pressure off your spring ligament repair, take the pressure off your tib post FDL tendon transfer. Essentially, what does that involve? You've got various modifications of the Evans procedure, or the lateral column lengthening as it's called. You can make a cut in the anterior process of the calcaneus, jack it open, and put a tricortical wedge graft in there, or you can do this correction through the calcaneocuboid joint. So you prepare the calcaneocuboid joint, you distract it and put a almost a bone block distraction arthrodesis through the calcaneocuboid joint. So let's go through this. So this is your approach. As you can see, the calcaneocuboid joint is just coming into view, just under that retractor. And what we tend to do is you want to make sure that your cut is fairly enough to not compress the calcaneocuboid joint when you distract it, and at the same time not impinge into the subtalar joint. And ideally, as you can see in that video, it's 1 centimeter to 1.5 centimeters from the proximal to the calcaneocuboid joint. So you measure that out and mark it out. Once we've done that, we put, as you can see, there's a guide wire in there, which I've passed to make sure that I can use that as a jig for my osteotomy, and that's the osteotomy which is being done. You can, a top tip, don't try to breach the far cortex if you can. So just sort of tap it and make sure it's sort of just about to give but not gone completely, because that's the hinge through which you can create your osteotomy. And once that's done, we then put a Hintermann retractor into the on either side of the osteotomy, as you can see, and basically distract it. And on the right, you can see the intraoperative image. The two guide pins are in there, and the Hintermann is distracting that osteotomy, and you can see the talar head has been covered. So intraoperatively, you keep correcting it, distracting it, till your talar head gets covered by your navicular. Once it's covered, you stop your distraction, ratchet that Hintermann, and then measure the width of your distraction. And that's the width of the graft that you're going to need. You do not want to go beyond 8 to 10 millimeters of graft thickness, because if you do that, that's when we start running into trouble. We start causing a compression of the calcaneocuboid joint and might give rise to arthritis due to compression in the future of the CCJ. We can impinge into the subtalar joint, which is what we call posterior facet impingement. So here is your distraction which has been done. And you can see that space which has been created. We measure that, we take your graft, and as you can see in the video on the right, the graft has just been placed into that osteotomy site. And don't do what I'm doing there, which is blunting my chisel, but you want to get a tamp and tamp that down. Some people just tend to leave it flush inside with no fixation. Particularly in the pediatric age group, people tend to just put a wire in there and take it out at the end of 4 weeks, 6 weeks, or even just leave it in there flush and then put the patient in a plaster. I tend to use a plate. You can sort of countersink a single screw in there as well. And that's that patient once the correction has been done. So you can see now there's a plate there in the lateral column fixation. And there is a good element of talar head coverage there in that patient. You can see it's less than 10% of that talar head is now uncovered, which is considered normal. And there is a reasonable correction of the talar declination, although I do accept this is a X-ray in a back slab. Sure.
Can I ask you a question there, Raheel? So it's sort of following on from Marwan's question from before. So you've done a medial calc slide, and you've also done a lateral column lengthening as well. If you did a lateral column lengthening alone, would that give you the degree of improvement of the geometry of the hindfoot, or do you think that it's necessary to do both?
As you alluded to earlier in the session, Amer, this is a three-dimensional deformity. Your lateral column lengthening is going to correct your abduction of the foot in the frontal plane of the foot. But your hindfoot valgus, which is in your coronal plane, is not going to be corrected by a pure lateral column lengthening. I'm not aware of any literature which suggests that just a lateral column lengthening will correct both your foot abduction as well as your hindfoot valgus. In fact, the risk of just using a pure lateral column lengthening is you might end up trying to distract more and more and put a thicker piece of graft in there beyond the 8 to 10 millimeters, which is routinely advised. And that might give rise to your posterior facet impingement and your subtalar joint impingement if you're being too enthusiastic with just a lateral column lengthening. I'm not aware of any literature which suggests just correcting with lateral column lengthening. I don't know if you are, but I wouldn't advise that.
I think it's in the pediatric yeah, I agree with you. In pediatric population, you can, sure. But not in an adult population. Yeah. The second thing is there are designer plates for lateral column lengthening with wedges built into them. Do you use those wedges, or do you consider that you actually want to have the structural integrity of having bone in there, and you use a plate just to span it and keep it in place until the bone is healed up?
With regards to literature, I'm not sure there's any comparison between wedge plates and bone graft. Personally, no. I would just go with a bone graft because it's just it's biologics as opposed to a metal in there. Where there are instances where you need to use wedges where you have massive bone loss, fair play, you can pack it with bone graft and use it. But this is an 8 to 10 millimeter thickness wedge which we need, and it doesn't take long to either harvest from the iliac crest or use structural graft. But that's my personal preference. It's got nothing to do with the literature. Okay. So here is a paper from Scott Ellis's group in Hospital for Special Surgery in New York. What they did was looked at the contribution of lateral column lengthening in the correction of the forefoot abduction. They looked at 40 patients at 2-year follow-up who all had lateral column lengthenings, and they found significant improvement in the AOFAS and SF12 scores. And this is the key take home from the paper, top tip for us in the pre-op planning. How much graft is enough? What thickness of graft is enough? So if we look at your forefoot abduction on an AP X-ray and measure it in our angles, the first metatarsal and the talar, long axis of the first metatarsal and the long axis of the talus, and look at the degree of abduction. Let's say there is 30 degrees of abduction. This paper has shown that 1 millimeter of graft thickness corrects the coverage by 6.8 degrees. So you can pretty much plan preoperatively what thickness of graft you want. And once you've cranked it and looked at it intraoperatively and covered it, you can double check to make sure that the thickness of graft you wanted matches up with your correction intraop. So that's a neat take home from this paper. So we've spoken about reconstructing as opposed to fusion for our flexible flat feet. A point to mention, if you have an elderly patient or if you have someone who is overweight and obese, you're probably safer off, even in a young patient, considering a DIPL fusion as opposed to reconstruction, because the bony forces of correction and the tendon transfers might not hold that foot up in the long run. But here is an interesting paper which looked at what do older, if we did a reconstruction, which is what we've discussed now in an elderly patient, would they do well? Because traditionally we've been taught to reserve a fusion for the elderly age group. So this was 137 patients against Scott Ellis's group. And they divided these into 3 groups: less than 45 years of age, 45 to 60 years, the middle age, and beyond 65. And they looked at foot ankle orthopedic scores and the need for further surgery in these patients. And interestingly, they found there was no difference in outcomes, both functional outcomes and the need for further surgery, in patients who were over 65 compared to those who were younger, 45, with a flat foot reconstruction. Now, do you find that interesting, Amer?
Well, yes, because it goes against what you might consider intuitive.
The with this paper. So as with all evidence, you can swing it any way you want. This paper has a follow-up of 2 years. So what you can say is safely for 2 years, 2.5 years, patients who are older than 65 will do well with the reconstruction. Beyond that, we've got to watch that space. Okay, so here's to summarize with regards the surgical algorithm. Work your way from the hind foot to your forefoot. Start with your Achilles lengthening or your gastroc recession. Once you've done that, it gives you better leverage with your calcaneus to swing it into a neutral position. So you do your medial slide calcaneal osteotomy. Once we've done that, you then move to the medial aspect of the foot and do our FDL tendon transfer. I haven't touched upon the fact that some people prefer to do a flexor hallucis longus transfer as opposed to a flexor digitorum longus transfer. Both are equally valid. They have their pros and cons. If the patient is young, have a low threshold to consider a spring ligament reconstruction at the same time as your tendon transfer. Once you've done all that, intraoperatively, you look at the forefoot. If the forefoot is still supinated, you want to correct it and bring it into a plantigrade position and consider a cotton osteotomy. So here is your take-home message. Hindfoot valgus, you've got your calcaneal osteotomy to correct with. For muscle imbalance, you've got your FDL tendon transfer. Forefoot supination, as we discussed, a cotton osteotomy. Your talar head uncoverage, if it's more than 30 to 40%, have a low threshold to doing a lateral column lengthening or an Evans. For your medial column instability, you can discuss various options. You can consider a first TMT fusion, an extended talonavicular or navicular cuneiform fusion. And if your foot is rigid, we know you're going to do a DIPL, which is an easy decision there. Okay, so in summary, in a flexible flat foot, as long as we follow the principles and the evidence that backs it up, most of the time, almost all the time, we won't go wrong. Do you have any questions from the audience, Amer? Or I'm going to stop sharing my screen and we can discuss.
So we've had one question from Waka, which is not about the surgical treatment, but it's about how long to continue with orthotics, even if the patient has a flexible deformity. And he's asking, would physiotherapy help?
What are your thoughts on this?
I always give my patients a trial of orthotics, and there's one paper which shows that actually quite a lot of patients, sometimes up to 80% of patients who have orthotics, especially in the elderly, they manage very well. But if you've got a flexible deformity, and that may be the only treatment that they require, because again, it's going to correct the 3-dimensional deformity. But it's important that if you're going to prescribe orthotics, you don't want orthotics which are made out of foam, because the foam orthotics, essentially, they will collapse over time. So the patient may love them initially because they're very comfortable, but over time they flatten out, especially if you've got an obese patient, and they will fail in their function. So you actually want them to have a polypropylene, a hard plastic orthosis, which is the same kind of material that your computer keyboard will be made out of. It's quite hard plastic, and even though it's more uncomfortable for the patient to begin with, they need to wean themselves into using it very slowly over the course of a month. And by the reason that it's painful is because you're effectively changing the shape of the foot. If you get them to wean on very slowly, then what will happen is that they will be able to gradually achieve that correction. And once it's got to the position that it needs to be in, and they have relaxed their soft tissues, then they'll be comfortable in that. Having physiotherapy, I do refer my patients for physiotherapy because I want to try and stretch out the gastroc or the Achilles, because that's an important component which is compounding the problem. Whether improving the power of tib post helps, I'm very doubtful, because most of these patients have got good, strong power in their tib post anyway. So does that answer the question? How long would you carry on for? I think I'd probably go with the orthotics for at least 3 months, because it takes time for them to get used to them, for it to gradually correct their deformity, for them to wean onto it, and then eventually, after 3 months, you should be able to assess whether it's worked or not.
Shall we move on to our final case before we wrap up? Just for those of you who are looking, we've just sent you a handout, a PDF on spring ligament. While Amer loads up the case and takes us through the case. And there's one more coming up on the Evans or the lateral column lengthening. So feel free to download that through your the link.
Okay, so our second patient is, again, fairly young, 36 years old, who's got a painful flat foot. And interestingly, this is combined with a painful symptomatic bunion. So they've tried orthotics and it hasn't been successful. So what are we going to be able to offer this patient? So here we have some x-rays. We've got a lateral, an oblique, and an AP. These are all standing views. So Raheel, could you just take us through the x-rays and tell us what you can see and what alarm bells might ring with each individual x-ray?
In the lateral view, we've got the complete collapse of the arch here. The Meary's angle is in negative. The calcaneal pitch is pretty much flattened out. And your talar declination, your talus is almost like a vertical talus there. It's, the declination is significantly increased. When you have these kinds of x-rays, the lateral, it's always a good idea to pass your eye over the distal part of the medial column. What's happening at the navicular cuneiform joint and the first tarsometatarsal joint? Is there an element of plantar gaping which is occurring there, which might suggest that there is instability in the medial column as well? Because you might have to address that when you're correcting your flat foot. Looking at your oblique, the oblique pretty much helps here just to look at the calcaneonavicular region to see if there is any beaking which may suggest a coalition, which I can't see in this x-ray. And on the AP, working from the hind foot towards the forefoot, you've got your talar head coverage, which you're looking for. It seems to be reasonably well covered there. You're looking at your first metatarsal talar angle to look for any abduction. And in this case, in fact, there is a significant amount of, there's a significant hallux valgus deformity present. So this lady has both these deformities. When you have a hallux valgus deformity, it's always interesting and important to look for any irritability in the first MTP joint, which might suggest any underlying arthritis. But in a 36-year-old, you'd be surprised to see that.
Would you be worried about inflammatory arthritis in a patient like this?
Because you've got a patient who's having attenuation of the capsule occurring in the spring ligament region. You're having attenuation of the capsule occurring in the first MTP joint. So you've got to look for an inflammatory component in this patient and do the workup.
Okay, so we've had a good look at the x-rays now. So the question that we'd like to ask you is, what are we going to offer this patient? So are we going to just deal with the flat foot first of all, or are we going to deal with both pathologies at the same time, or does it not really matter?
So there is the safe answer, and the right answer in my hands would be to consider just a flat foot reconstruction. Okay, I would try to urge the patient that this is significant surgery, bearing in mind that there are multiple components to your flat foot reconstruction. If I was considering a distal metatarsal osteotomy, I would go strictly in a staged fashion here. Let's see, so majority of the audience seems to suggest correct both. Fair play to them, but it's a lot of surgery in one sitting. And if you're considering a distal metatarsal osteotomy, I would be concerned about the number of scars and incisions in that foot. However, if the correction of the bunion is occurring through the proximal aspect, maybe through a, if the first TMT joint is unstable, through a lapidus, then you could just extend your medial incision and do that. So that would be my thinking, although I am loath to do both together.
Okay, so it looks like from the answers, more people are going for a combined approach, but often, this is something that's going to be decided by the patient, because you've got to give them the options and give them the risks and benefits from both approaches. So let's move on to the next slide. So the question that we'd like to ask is, which step is crucial in realigning the talar orientation? Is it going to be the recession of the gastroc, the lateral column lengthening, the calcaneal osteotomy, or none of the above? So we've talked about this in your talk. So let's give everybody a chance to make a decision. So we're still waiting for quite a few people to make a choice. I'll remind you that this is completely anonymous. We don't know who is choosing whichever answer. So please do feel free to participate and make a choice.
The audience is answering that poll. We're going to just share with you a document, a PDF on pearls and pitfalls with calcaneal osteotomies, how to do them, what to look out for, and the different kinds of calcaneal osteotomies. So feel free to download that as it comes across on your screen. So this is an interesting one, Amer. How would you, which is one of the crucial ones? So there is no right or wrong answer with this. Okay, it was more to just get a sense of discussion. But I do believe that a gastroc recession does help to improve the talar declination. I'm not sure what your thoughts are on that.
Is that? Do you think that's working because it's actually neutralizing one of the deforming forces, i.e., sort of the pull of the gastrosoleus, which is contracted into the valgus position?
I think the lateral column lengthening will help with the talar orientation, possibly, but the declination maybe not. Okay.
So which answer would you choose?
I would go with the
from those four. Okay. What about the lateral column lengthening? Is that going to make any difference?
Seems to think that
a lot of the audience believe that.
Fair to them, it may help with your orientation in the AP plane because you're jacking out that lateral column, so it's covering the talar head. But in the sagittal plane with the declination, I don't think that's going to make much of a difference. So just as a take-home message, the talar declination, which is the sagittal plane movement, will not be redressed to a large extent with your lateral column lengthening, I feel. Okay, correct me if I'm wrong, Amer. But the talar head coverage, for sure, the orientation from the talar head coverage will be improved with your lateral column lengthening.
What about the calcaneal osteotomy? Is that going to reorientate your talus as well?
I suspect all of these, to a certain extent, in some way or the other, will help with the talar orientation. But the question here is, which is crucial one? If you had to pick amongst these, it's not a right or wrong question, once again. And we pose these
absolutely
to stimulate discussion. and see where we are at as a group. So yes, it could.
And perhaps actually we could have actually included another answer if we'd said all of the above. That might have actually been a better way of approaching
most of us would have gone for. Yes.
Yeah. But I think that each one of these does contribute. And as you say, the calcaneal osteotomy will correct it in because of the orientation of the osteotomy. You're not going to get a three-dimensional correction from that. The lateral coloning will help, and by getting rid of one of the deforming forces, that will gastroc recession will also help as well. So it's an interesting question, and there's no right or wrong answer for this one. Apart from perhaps, I think answer 4 is incorrect because all of them do contribute in some way. Okay, so we've now got another question. So what would sway you to perform a spring ligament reconstruction? It's something that we've talked about. So would it be the patient's age? Would it be tenderness along the course of the spring ligament, or would it be that you'd have to have evidence on the MRI that there's a problem with the spring ligament before you do something about it?
There is no right or wrong answer with this. So the idea of these questions is to see what we do in our practice. How do we? There are subtle changes to each from practice to practice. There is variance. We know that spring ligaments tend to have a role to play with flat feet in the young age. So yes, a patient's age would certainly suggest a spring ligament pathology. It depends on how many of us actually put our fingers on that spring ligament and examine it to look for tenderness. And you need to be fairly experienced and nuanced to differentiate between a tib post and a spring ligament to an extent. Most of us who do foot and ankle full-time will be able to pick this up. Now, do you tie that in with an MRI to confirm your findings before you dive in and do a spring ligament repair is the question. How does this work in your practice?
So I would always get an MRI scan before I'm going to operate on a patient with a flat foot. But I wouldn't always rely on the MRI scan to be able to pick up that spring ligament injury, because sometimes you may get a high signal which would confirm your sort of thought that there's a spring ligament problem. But sometimes you don't have any spring ligament evidence of a tear, but there may be a little bit of stretching which has led to sort of the mechanical failure, and that might not appear on an MRI scan. So although I get an MRI scan in any case, I wouldn't just rely on that. And like you say, if it's a younger patient, I would be very suspicious that there's an issue with the spring ligament in any case.
Finally, we get to a point where we can diverge, Amer. Okay. So you always get an MRI in a patient to assess for a spring ligament, when you're operating on a flat foot for reconstruction. So here is where I tend to disagree with that. If the patient is over 40, and I'm suspecting predominantly a tib post pathology rather than spring ligament, I might repair the spring ligament intraoperatively as a decision. I'll have the kit on standby. I almost never need an MRI, because the MRI is going to show what? That the tib post is tendinopathic. We know that. How is an MRI going to change your management plan? For me, an X-ray will show talar head uncoverage, will show increased talar declination, which may suggest a spring ligament pathology. I could address that intraoperatively. But we know we're going to sacrifice.
So who do you think overestimates or underestimates the degree of the pathology? Do you think that the radiologists overestimate, or do you think that we overestimate or
I think we
underestimate
the pathology? We do.
Yeah. So actually, there's evidence in the literature, in the radiology literature, that they will be more correct, and we tend to underestimate the pathology. So you might get some additional information from an MRI scan, and that's why I do it.
Great. So any sort of final thoughts before we round up? Top 3 take-home messages from this talk? Okay,
well, there's one more question from Marwan again. So the question is is resuturing the FDL after tunneling it in the navicular bone, or do you just fix it by the anchor? So do you wrap it around and suture it back on itself, or do you use anchor or both?
If you've got a fairly good press fit interference screw or swivel lock or fast fix, whichever you want to use, you don't need to resuture it back onto itself. The resuturing back onto itself technique was something which, if you've got enough length, by all means, go ahead and resuture it back onto itself. But you don't need to, particularly with the advances in our kits that we have now, because we have a really good press fit through the tunnel. So that's why it's important to drill a hole which is going to accept both the interference screw as well as your tendon, plus the two limbs of your spring ligament repair, whether you repair it with a fiber tape or whether you use autograft like a hamstring to do your spring ligament repair. Either, you don't necessarily need to resuture it onto itself unless you're concerned.
Okay, and there's another question from Moez. So if the tib post looks intact or healthy, do you advance it to the medial cuneiform? That's an interesting question, because thanks Moez, because in some people's practice, people do an advancement of the tib post as an alternative to doing a tendon transfer.
More welcome. Glad to have you. So this is an interesting one. And this is why forums such as these are interesting, because it stimulates these kinds of discussions. Now, in my practice, routinely, I would have sacrificed the tib post and just done an FDL tendon transfer. But more and more, I think, why am I sacrificing a healthy tib post tendon in a young adult? Okay, now there are some people who tend to retract that tib post tendon inferiorly, just repair the spring ligament, and then leave it in situ as is. They must be better surgeons than I am, because I struggle. I've tried it, where I've tried to just displace the tib post inferiorly with the retractor and tried to get your spring ligament reconstruction done, and it's an absolute nightmare. So I think there's a huge, what you say is a very valid point, more where you can excise the tib post if it's healthy, and then just reattach it and advance it if you want to get the tension right. So Amer, do you have any thoughts on that? I think Mo's got it spot on there.
No, that's fine. We've also got a question from Marwan again, who's asking,
so
how do you adjust the tension of the tendon?
Marwan, thanks for asking us. Maybe I didn't stress during the course of the talk. What you need to understand is that the tendon tends to stretch with time. So it's really important to plantar flex your ankle, full plantar flexion of the ankle, and full plantar flexion of your foot. So bring that foot into as much plantar flexion and inversion as possible, and tension and tighten it. So you will actually end up with a bit of an overcorrected foot. Your foot goes into a bit of inversion and cavus when you've finished. But believe you me that once that patient starts walking, it will stretch out and it'll tend to get normal with the passage of maybe 3 to 6 months of weight bearing. So it's really important to get that tension by plantar flexing the ankle and plantar flexing the foot and inverting it to an extent as much as possible, and pulling on that FDL through the tunnel as much. Get your assistant to pull as much as possible on that FDL, and then put your interference screw in. I don't know if you do anything different, Amer?
Just to No, that's what I was. I just wanted to try and clarify. So you're wondering how you get the tension. Well, you get the tension by, you've got a whip stitch in the end of your FDL. You pass that through your tunnel, and your assistant is pulling on that as hard as possible. And whether you suture that back on in itself or you use an interference screw, it doesn't matter. It's because you have got the foot in the position of maximum plantar flexion, and it's your assistant pulling on the FDL whip stitch, which is going to give you your tension. And that's how you're going to lock it with either your interference screw or by suturing it back to itself. Okay, so Morris has got another question. Have you ever had a blowout?
This is an interesting one, and we touched upon this in the talk on how to avoid a blowout of the navicular. Amer, have you had a blowout? I have so far not had a blowout, but it's only a matter of time, I guess. I have had to fish out a screw and fix a navicular in a patient who had a blowout and turned up in my clinic, and it is a bit of a nightmare doing that. So the way I try to avoid that is I'm almost OCD when it comes to getting. So I tend to use the ACL tray, as I alluded in the talk to. So I take the wire from the ACL tray within the eyelet, and I pass it into the navicular, and I take multiple live screening shots to make sure I'm in the center of that bone before I pass the drills. Again, from the ACL tray, the drill, depending on what size I want with my, I normally use a 4.75 anchor through the navicular. So I'll go one up with my drill bit. So the key here is to reflect your flaps quite dorsally and plantarward. So you're seeing almost the whole of that navicular. So just don't go into that medial medial aspect of the foot with your incision. Reflect it dorsally and plantarward, so you can see that body of the navicular, and you're quite confident that you're not too far medial with your drill tunnel, because that's what causes the blowout. Your thoughts, Amer?
Well, I'm lucky I've never had a blowout so far.
We both know what complication we're going to end up with in the next few weeks. Yeah.
That's one we'll both be afraid of.
Does anyone in the audience have any thoughts on that? Please feel free to, if you want to speak, we're happy to open up the microphone to you.
Well, let's ask Moez. Have you ever had a blowout, Moez?
I think Moez
is that why you're asking?
I'm not sure we can give him the mic. But Mo,
okay.
Feel free to.
Okay, but type your answer if you.
Great. Yeah, he's a good surgeon.
Okay, so none of us have actually encountered that, which is
okay. So
probably good
what
news.
to do with the blowout? Okay, that's a good one. So if there is a blowout, I think we've burnt our bridges with the navicular. We've got to just fix the navicular with probably a screw. Hope to God that we've got enough length on our tip post to, the FDL tendon transfer to advance it into the more distal bone, which is the cuneiform. That's what I would do thinking on my feet. I'm not sure if anyone else has any thoughts on that. Amer?
Well, I was just thinking it depends on whether you've still got a tib post.
No, sorry, the FDL.
FDL or FHL, especially if you. Yes, but if it depends whether you've burnt your bridges if you've cut your tib posts, but if you haven't taken off the tib post because it's got such a big footprint, because it inserts into so many different bones, transfer, then you.
That's Moise's question.
Yeah, but as I said, it depends whether you've sacrificed the tib post or not.
Great. Do we have any other questions? If not, we're going to wind up. This was the foot and ankle theme at the OrthoNinja Academy. Just to let you all know, we're going to change tack. We're going to have the knee surgeons taking over. We've got a great faculty, international faculty, which is going to be dialing in and taking over the Khan at the OrthoNinja Academy. And we're going to keep you posted. It's going to be happening soon. So check us out on the website, and we'll have updates. But we're going to have a full-fledged knee team. Amer, do you have any final thoughts before we close down the foot and ankle theme?
No, I just want to say thanks very much, Raheel, for a really interesting and informative talk. I've learned loads today. I'll have to go and implement that back in my practice. But it's been really useful to sort of see what the audience think about the questions that we need to pose during decision making. And thanks to everybody for their feedback as well.
If you do have any suggestions on how to change things going forward, please do let us know. Feel free to contact us, and we're more than happy to take on board your suggestions. Thank you, everyone. Thank you, Amer. Good night.
Okay, good night.